Hi everyone, this is Mr Neel Raithatha, also known as the Wax Whisperer. Thank you for joining me in my latest video. This is of a patient who attended with earwax in both ears, and in addition, this is the patient's left ear, and this is the external part of the ear, the satellite dish on the outside. We call that the pin end. You may have seen there, they've got a skin tag. Now, sometimes these skin tags can be cancerous. Fortunately for this patient, it's not. Nonetheless, they are still waiting for a procedure to have that removed, just in case it can potentially turn malignant in the future. And we're just commencing with the patient's left ear. The patient has got narrow ears now. They do have to attend every year. And incidentally, that skin tag wasn't there a year ago, so it's just formed in the last 12 months since I saw the patient. And I am just performing microsuction here. Now, the term microsuction, initially I was under the impression the term microsuction was because the procedure used to be performed under the view of a microscope, and hence the name microsuction. Now, some may contest that is the case. However, these ENT instrumentations we use to remove earwax and other objects from our bodies from the ear, because they're so small, they're actually called micro instruments, and therefore the term microsuction, I feel, it more relates to because we're using a really small suction probe, basically, hence the term micro. However, there might be different views about that, and we've just removed all the lateral wax. Lateral wax is the wax building up near the entrance. This is more medial. This is up against the patient's eardrum. You can see it's quite dry and crumbly. This last piece is actually adhered to the eardrum. And I'm just going to go to the back part of the ear canal because it does extend onto this part, and just remove that section first. And then just going deeper. And it's just this last piece that is also attached to the roof of the ear canal. This type of wax is quite satisfying to remove, actually. It comes out in pellets. There's very little manipulation that's required with the suction probe. The suction does the job more or less. And it comes out in big pieces. So the ear canal is completely clear now. You can probably see the curvature of the patient's ear. So this is the left ear. So we get the first bend just to the right. You can see the cartilage there. Then where I am now, just about a few millimetres further forward, that's the second bend, and the eardrum hides behind that second bend to the left. So it's like a meander, there's an S bend there. I'm just mopping up using the fine end suction probe. Now, patient's hearing's fine. We could have just left all this. Because this section is on the cartilaginous portion, we can put a bit of pressure here. It's not going to hurt the patient. On the bony part of the ear canal, we want to be a bit more delicate. So I've got a clear wax course tomorrow. One of the things I will stress is not to especially in the early stages, do not over clean the ear. Now we're using a fine end suction probe here, so it's a lot quieter. So suctioning can be quite noisy. So again, you don't want to overdo it in the ear because it can be problematic for the patient sometimes, because with excessive exposure to loud noise, you can develop either temporary or permanent hearing loss. So loud sounds, extremely loud sounds, looking in excess of 85 decibels and above, what they do, we've got microscopic sensory hair cells in the organ of hearing called, there's two types, there's outer hair cells and inner hair cells, they're called cilias, and they distort in shape in response to loud sounds. Without getting too technical, but these little hair cells, they have almost like a strand of hair sticking out on the top of each of the cells. And in response to loud sounds, that little strand contracts, and it shears to one side, the hair cell itself contracts, and it distorts and disfigures in shape. And you get a lot of buildup of chemicals in there, all these toxins, as that hair cell's undergoing strain, trying to process all the sound. And if the sound is too loud, that hair cell, the little strand, can shear too much and snap or coil over. The hair cell can rupture and die, or there's too much chemicals, too much toxins, and the ear's not quick enough to expel it. So the hair cell almost denatures. So excessive noise can cause that. Excessive noise can vary in terms of a single episode, for example, a gunshot, or exposure to moderately loud sounds over a period of time. So, for example, if you're working in a noisy factory and the decibel level is 85 or 90 decibels, if you listen to that for the course of the day for many years, for example, that also can cause, over time, noise-induced hearing loss. So suctioning at its peak, when we do microsuction, that's what we're doing now. At its peak, if you're really close to the eardrum and there's a bit of skin there that clarinets, it can be in excess of 130 decibels. And being exposed to that level of sound for less than a minute, even probably less than that, can actually cause either a temporary or permanent threshold shift. So when we say threshold shift, we mean a reduction in hearing. Also, it can induce tinnitus. So tinnitus is a noise that originates within the ear as opposed to a noise in response to an external sound. So loud sounds can cause your ears to ring and buzz. I think we've all been there in a busy club or a nightclub or a bar after leaving. If it's really noisy for the next 24 or even 48 hours, your ears can ring and your hearing's not great as it's trying to recover from the noise. So sometimes less is more. That's something that we'll stress tomorrow. Now, with experience, you kind of go in and out at certain points, so you're not overexposing the patient's ear all in one go. And sometimes it's the way you position the suction probe onto the wax, so you minimise the noise. Sometimes it's very difficult. It's just it's noisy, and you're trying to figure out how to reduce the noise, and there's no other method of removing wax other than suction. If possible, I always try and remove wax using other instrumentation if it's safe for the patient to do. But fortunately, I've never had any episodes myself where I've had patients probably temporarily for less than 30 seconds. Happened to me. I think someone's been in my ear before and I noticed a temporary change, but within, 30 seconds of my hearing, it was back to normal again. So, again, just mopping up the back of the ear canal near the entrance. We're using the fine sucker here, so it's really quiet. It's much quieter than the normal sucker. When I have this performed, not that I get wax ears, but when we're training people, sometimes we'd get delegates who practice in my ear, and the fine end suction probe, actually, I find it a bit therapeutic. It's a nice level and intensity and type of sound, and it can relax you almost. Again, we're just near the entrance, just on the cartilaginous portion. I'm going to leave all that because I think it did clarinet a bit. That's the eardrum, nice and healthy. So that's the remnants on both ears. I hope you enjoyed that video, guys, and you're all keeping well and safe. Just speak to you soon, and stay tuned for more videos. Thank you, bye.